A warm welcome to everyone in the anesthesia classes. The topic that we are going to cover today is complications in anesthesia. See, anesthesia per se is intrinsically hazardous, and the complications in anesthesia can occur intraoperatively as well as postoperatively. So let's start with the very first complication, which is also very commonly asked in your exams also. That is the aspiration pneumonitis, also known as the Mendelssohn syndrome. Mendelssohn syndrome or aspiration pneumonitis, as the name suggests, it is the aspiration of sterile gastric juices in the lungs which lead to pneumonitis. What actually happens in pneumonitis is we have, because of the sterile gastric juice, we have an acute inflammatory response that leads to interstitial edema, then ventilation perfusion mismatch. There is reduction in the compliance of the lungs, eventually leading to a ground glass appearance or acute respiratory distress syndrome. Aspiration pneumonitis have two main predisposing factors which are generally asked. One is the gastric volume, that is at least more than 25 ml has been seen as a predisposing factor for aspiration. And second is pH less than 2.5. But when we talk about the pediatric patient, in that the gastric volume is zero point 0.4 ml per kg. This is for the pediatric age group. In adults, it's 25 ml, pediatric 0.4 ml per kg with pH less than 2.5. The patient can present asymptomatically also, and also with features of respiratory distress like tachypnea, bronchospasm, wheeze, cyanosis, or respiratory insufficiency, eventually leading to ARDS. Such patients have a history that maybe the patient was full stomach at the time of induction, patient vomited, and eventually we could hear the creps in the saturation began to fall. We could hear the creps in the chest. So what would be the diagnosis? So the diagnosis is aspiration pneumonitis or Mendelssohn syndrome. This is actually that case scenario that comes, that it tells that it's a full stomach patient or any condition which could lead to full stomach like pregnancy, obesity, or certain LES incompetency, that is lower esophageal sphincter is incompetent, like in pregnancy the progesterones which are responsible for the relaxation of the LES, they increase. Then in certain condition where we have the laryngeal reflexes which have been abducted by us, like we have given the induction agents in a full stomach patient and the patient has vomited. Then there could be operating factors like an emergency case, a trauma case has been taken in the OT and we don't know the status of the nil per oral. Then the laparoscopic cases which increase the intra-abdominal pressure, even those patients are predisposed to aspiration of the gastric juices. Lithotomy positions. Then anesthetic factors could be the gas insufflation during pneumoperitoneum or the gas insufflation during the bag and mask ventilation, because generally in bag and mask ventilation a major part of the gas goes inside the stomach also. Then difficult intubation cases could also lead to aspiration pneumonitis. It could be one of the predisposing factor. And lastly, inadequate depth. So actually how the diagnosis of aspiration pneumonitis you have to make is that one case will be given which will be suggestive of more or less something which is related to full stomach, and the patient has eventually landed up into respiratory failure or is showing the signs and symptoms of respiratory insufficiency, which is pointing towards ARDS. The predisposing factor you all have to remember are two: gastric volume less than 25 ml have to be there, more than 25 increases the risk, and pH less than 2.5. When we talk about the pediatric patients, it is 0.4 ml per kg. And then comes how you can prevent it. The very first prevention is the fasting guidelines. I hope you all remember the fasting guidelines. That is 2, 4, 6 and 8. 2 for clear liquids, 4 for breast milk, 6 for non-human milk or light meals. Light meals. And 8 for heavy meals. Second is we have to reduce the gastric acidity, which can be done by using your H2 receptor antagonists, or you can have 5-HT3 antagonists. You can have your PPIs, that is proton pump inhibitors, and generally in certain cases we also use particulates like sodium citrate, which are given to decrease the gastric acidity. And lastly, in patients who have a full stomach, there we can use a maneuver known as the rapid sequence intubation or Selix maneuver. See, what does rapid sequence intubation means is that we have to intubate the patient rapidly. The positive pressure ventilation, the time for positive pressure ventilation has to be minimal in such patients such that gastric insufflation is minimal. What we do is that when we take the patient, the first thing is that we generally first pre-oxygenate the patient properly. When you have to give RSI, pre-oxygenate the patient, let the patient breathe on his own spontaneous ventilation. And second, as soon as you give your induction agent, you start giving the induction agent to the patient, what you do is you put a pressure on the cricoid cartilage such that the cricoid cartilage is going to press against your esophageal sphincter and obstruct it against your vertebral bodies. This is how the pressure or force has to be applied, which has to be around 20 Newton force. And this has to be released only when the patient has been successfully intubated and the cuff of the tube has been inflated. After this step only we have to release this pressure. Why cricoid cartilage is used is asked as an assertion. The reason is that cricoid cartilage is the only part of the larynx that is a complete circle or a complete ring. Okay, so this is the pressure is given at the cricoid cartilage, and thus we obstruct the esophageal sphincter such that the gastric contents don't go into the trachea. That is your RSI. Then during RSI, one thing we have to be careful about that after giving induction agent, we do give the intubation or the muscle relaxants also. The muscle relaxant of choice for RSI are two. One is scoline and other is rocuronium, because both of them have rapid onset. The only difference is that scoline can be preferred in those patients in which you are expecting a difficult airway or difficult mask and bag ventilation, because rocuronium has a longer duration of action, whereas the scoline effects weans off within 5 to 10 minutes. So when you are expecting a difficult airway, then please don't attempt RSI along with rocuronium until and unless you have Sugamadex in hand with you. Now, if aspiration pneumonitis is suspected, so the next line of management would be you have to provide the patient with oxygen, suction, and head down tilt has to be given to the patient such that the gastric contents, they don't go inside the trachea and they come out from the mouth where you can suction. Okay. One thing you all have to remember is that there is no role of prophylactic steroid or antibiotic in such patients. There is no prophylactic role. Once it has happened, then yes, at that time antibiotics or steroids, oxygen, suction, nebulization, everything is given to the patient. Then we come to the second intraoperative complication, that is the bronchospasm. See, what is bronchospasm is? It is a hyperactive response of your smooth muscles of your bronchi, which could be mechanical or chemical in nature. And thus your bronchial muscles start constricting. And when they constrict, we have respiratory insufficiency. Now, the causes of bronchospasm, the main cause of bronchospasm is inadequate plane of anesthesia. The main cause of bronchospasm is inadequate plane of anesthesia or the introduction of certain irritants to the airway like isoflurane, desflurane, even the NSAIDs, neostigmine, thiopentone, atracurium, mivacurium, and opioids, all are seen to be responsible for the bronchospasm. When the case of bronchospasm comes, this is how the case would be coming like that the patient intraoperatively suddenly is developing, there's a gradual decrease in saturation of the oxygen. Breath sounds are present, but yes, they could be reduced, and you can have an expiratory wheeze. The characteristic finding of bronchospasm is expiratory wheeze with prolonged expiration, such that in your EtCO2 you have a shark fin like appearance. In EtCO2 you have a shark fin like appearance. In EtCO2, you have a shark fin-like appearance. Okay, this is a shark fin in which the expiration is taking a lot of time. So the characteristic finding in your question would be a shark fin pattern of EtCO2, or they would specify that the rate of emptying of the alveoli have increased and the patient has a peak airway pressure which is also increasing. This is where you point towards bronchospasm. The prevention from bronchospasm is that if the patient has a history of COPD or asthma, the medications for the same have to be continued throughout perioperative period. The patient has to stop smoking and nebulization of the patient has to be done properly. If the patient is a known asthmatic or COPD or a chronic smoker, it is always preferable to take that case under regional anesthesia or after the introduction of supraglottic devices. Now, how do you manage bronchospasm is asked. First, we have to provide 100% oxygen to the patient. The surgeon has to be asked to stop manipulating, and if possible, we have to ventilate by hand because the peak airway pressures have increased, and seeing the compliance of a reservoir bag, we can decide how much pressure has to be given to the chest such that it inflates properly. Okay, so the first is stop all the stimulation, whether it is mechanical or pharmacological. Ventilate by hand, give 100% oxygen. Deepen the plane of anesthesia if it is inadequate. Give propofol, it is a very good bronchodilator. Give inhaled nebulized salbutamol or racemic epinephrine to such cases. There is no role of skeletal muscle relaxants in such case because bronchus is a smooth muscle. So drug of choice for bronchospasm is inhalation of or nebulization by salbutamol, which will lead to bronchodilation. Then we have anaphylaxis, yet very common and important complication, but a life-threatening complication. The triggering agent for anaphylaxis could be any. It could be your antibiotic, your muscle relaxants, your local anesthetics, even the colloids, the latex which can be seen in the gloves. Anything can lead to anaphylaxis. The anaphylaxis is actually nothing but a hypersensitivity reaction of our body, a very severe acute hypersensitivity reaction which can range from only urticarias and cutaneous rashes to angioedemas to arrhythmias, bronchospasm, and eventually leading to cardiovascular collapse. So, anaphylaxis could be a life-threatening complication for the patient. When we talk about the management of the anaphylaxis, the very first step is resuscitation of the patient, and the drug of choice for anaphylaxis is adrenaline. Now, how do you give adrenaline? Either IV adrenaline is given 1:10,000, 50 microgram. You have to remember the doses and the routes by which adrenaline is given in anaphylaxis. IV adrenaline 1:10,000. You actually have an adrenaline vial of 1:1000. You dilute it by 10 to get 1:10,000, and 50 mics are given of this 1:10,000. But when we talk about IM adrenaline, then the same adrenaline, that is 1 is to 1000, is used, and around 500 mics of adrenaline are given IM. Other than that, AVIL, that is your chlorpheniramine, hydrocortisone, or even nebulization can be done of the patient in order to relieve that bronchoconstriction in the patients. Then we have the laryngospasm. This is one of the commonest complications, especially at the time of extubation. What actually happens is the difference between bronchospasm and laryngospasm is that is the constriction or the closure of your bronchioles. One lung bronchioles have been closed, the second lung is still there. So the saturation of the patient does not fall very fast, and it does give you some time. But when we talk about laryngospasm, it is nothing but reflex closure. That is, the adduction of the vocal cords is there because of the glottic muscular spasm. Your vocal cords are partially obstructed. They could be partial as well as complete airway obstruction. If there is laryngospasm, it means hypoxia is going to be severe. Arrhythmias, pulmonary edema, negative pressure pulmonary edema happens in laryngospasm. I repeat, negative pressure pulmonary edema, because the air has to flow against an obstruction. It is negative pressure pulmonary edema, eventually leading to cardiac arrest. The pathophysiology of laryngospasm is that there are certain irritants, which could be your secretions, which would be your manipulation during your extubation, which hyperactivates the superior laryngeal nerve, which is responsible for the glottic closure. The risk factors for laryngospasm are inadequate depth, irritant volatile agents like isoflurane, desflurane, and yes, an extubation in the hands of inexperienced anesthetist can also lead to laryngospasm. We can have irritants like saliva, blood, vomiters, any foreign body, or your airway equipments per se. Then surgical stimulation can be like during the transfer, or the anal cervical reflex, that is your Brewer-Lucard reflexes. Laryngospasms are very, very important, and a lot of questions are asked from laryngospasm. The clinical features of laryngospasm is stridor. They would be stridor because it is at the level of the glottis, whereas there is wheeze in bronchospasm because that is at the level of your bronchioles or respiratory zone. In stridor, we have that harsh pitched noise on inspiration, which you can see by the movements also here. You have a tracheal tug, the use of the accessory muscles of respiration, intercostal and supracostal, supraclavicular, you have recessions. The respiratory pattern is paradoxical in nature. We have desaturation, cyanosis, bradycardia, which can eventually lead to hypoxia and brain dead. How do you prevent it? The one thing is that you don't have to extubate the patient in mid-plane of anesthesia. Either you have a deep extubation or you let the patient regain his consciousness. Kindly recognize the risk factors, like if some irritants are there, or use certain things which could deepen the level of anesthesia at the time of extubation, like lignocaine can prevent the laryngospasm. Give fentanyl, Maxilf to the patient and remove all the irritants. And once if laryngospasm happens, we have a silent chest also. Once there is stridor is the time when you have to catch that yes, laryngospasm has occurred. Okay, because eventually from stridor you'll have that seesaw pattern of respiration, and finally the patient is going to land up in a silent chest because of the complete closure of your glottis. The treatment is Larson's maneuver. Larson's maneuver is that you have to pull, or you have to put pressure just below your styloid processes, just behind your ears. A pressure has to be pulled and the jaw has to be anteriorly deviated or anteriorly directed for the Larson's maneuver. But the first step that you all have to do, if laryngospasm happens or the question states that such condition has happened, so what next to do? Next is you give positive pressure ventilation to the patient by giving the oxygen flush. After that, deepen the plane of anesthesia, call for help, remove all the irritants. Deepen the plane, give propofol to the patient. Patient is still not coming out, so directly give a skeleton muscle relaxant before the saturation falls too far, because your larynx is a skeletal muscle. So as soon as you give your drug, it is going to open and relax. Then we have perioperative hypothermias. See, we know very well that intraoperatively we have a lot of loss of heat from the body, which could be via your radiation, evaporation, conduction, or convection. Generally, what happens in our body is that when we start feeling cold, the receptors go to the anterior spinal cord. That is where they carry the cold fibers. From that, it goes to hypothalamus, and then we have that certain behavior or autonomic responses which our body gives in order to protect ourselves from hypothermias. Hypothermia is defined as the core body temperature less than 36 degrees Celsius. But what happens is that our anesthesia or the anesthetic drugs are going to disrupt these hemostatic mechanism. And sweating is but preserved. Just remember this. This is a question that what is preserved in all the autonomic responses? It is the sweating that is preserved. Okay. The most common method of loss of heat from the body is radiation. The consequences of hypothermia is that it increases the blood loss because of the coagulopathies it causes. So we can have surgical site bleeding, as well as it increases the chances of surgical site infection. It increases the length of hospital stay and the PAHO stay. And yes, we have a decreased drug metabolism in hypothermia patients. If we see because of hypothermia, there is one problem that occurs, and that is shivering. We have post-anesthesia shivering as well as intraoperative also. The patient can shiver, especially if we are doing the case in regional block. Such shivers are known by the name of halothane shakes. Such shivers are known by the name of halothane shakes. The drug of choice for such post-anesthesia shivering is pethidine, followed by tramadol, clonidine, and even Maxilf are being used. But the most commonly and effective drug is pethidine, followed by tramadol. How can you prevent the hypothermia? First, how do you monitor hypothermia? If you all remember, we have a core monitoring, we have a peripheral monitoring. The core monitoring is most accurate, like we can monitor using a transesophageal probe, or we can monitor through the tympanic membrane also. The esophagus temperature, the tympanic membrane temperature, they are more or less same like the core body temperature. How do you prevent hypothermias? We can have passive insulation, or environment could be warmed, or active. You can give warm fluids to the patient. You can have radiant heaters. You can have bare huggers. You can have forced air warmers for the patients. Then come to yet other very rare condition, but still very much asked condition. That is the malignant hyperthermia. See, when we talk about malignant hyperthermia, it's a genetic hypermetabolic state. What happens is that there is a triggering agent which could be your inhaled anesthetics or scopolamine. These are the two drugs which have been seen to produce malignant hyperthermia to the maximum. What happens is, pathophysiology is, we have calcium receptors known as the ryanodine receptors on chromosome 16. These ion channels are responsible for calcium being released from sarcoplasmic reticulum. And there is mutation in these receptors, and we have a uncontrolled release of intracellular calcium, which leads to inhibition of troponin, and we have a sustained muscle contraction because of availability of so much of calcium. We have an increase in the oxygen consumption, which is very similar to that of hypothermia. Please remember, if the question states that the patient is shivering, the first thing that you all have to do is please put oxygen mask on the patient, or eventually he'll end up to respiratory failures. So malignant hypothermia, we have an increase in oxygen consumption, hyperthermia, increased CO2 production. How do you monitor your malignant hypothermia is the gold standard is still increase in EtCO2, which is followed by fever or palpitations, dizziness, etc. You can have hypertension, tachycardia, arrhythmia. The out of this, the first thing that comes is increase in EtCO2. Then comes fever. Okay. Then we can have characteristic finding which can be mentioned in your exam questions also. That is the masseter spasm. This muscle has a spasm. Okay, when there is malignant hypothermia. We can have myoglobinuria. We can have increased serum creatinine kinase, and a generalized rigidity of the patient has been observed while malignant hypothermia. We can have fever, we can have sweating. Other than that, the electrolyte imbalances which can be seen in malignant hyperthermia is we have RBC lysis, so hyperkalemia. We can have hypernatremia, hypophosphatemia. All hyper things, hyperkalemia, hypernatremia, hyperphosphatemia. We can have DIC, cerebral edema, seizures, hepatic failure. The most common cause of death in malignant hypothermia is multi-organ failure. Now, how do you make a preoperative diagnosis? First, the history of the patient is very important. If he remembers that a certain thing happened in the history, in the family itself, or he could recall something of his own personal experience. Okay. The preoperative diagnosis of malignant hypothermia can be made by using your halogen caffeine contracture test. Just remember that this is a muscle biopsy which has to be carried, and this is halogen caffeine contracture test. The first premonitory sign is masseter spasm after scoling administration. We have the spasm of the masseter muscle and lateral pterygoid muscle. Please remember this. The spasm is that of your masseter muscle and lateral pterygoid muscle. And the most common and sensitive sign of malignant hypothermia is sudden and abrupt and very high rise in EtCO2. Please remember, hyperthermias are a late sign of malignant hyperthermia. The treatment is that you have to stop the resuscitation, the triggering agents there itself, and start resuscitating the patient according to the multiple organ failure is present or not. The drug of choice for malignant hyperthermia is dandrulan sodium, which is added to water 2.5 mg per kg, followed by 1 mg per kg for 6 hours till 24 to 48 hours. This is the dose for dandrulan sodium. I repeat, it is added or it is made with sterile water 2.5 mg per kg, which is followed by 1 mg per kg every 6 hours for 24 to 48 hours. When we deal with malignant hypothermia, it's very easy. What we have to deal is we have to treat the acidosis, the hypothermia part, the hyperkalemia, arrhythmias, and we have to prevent the renal dysfunction, because myoglobinuria is produced. Myoglobin is produced, so you have myoglobinurias, which are a little toxic to the renal cells. Then yet another very important complication that occurs is venous air embolism. This occurs when your operating site is actually above the right atrium, or the vasculature in the field is totally exposed to the atmosphere. The predisposing factor for venous air embolism are when the patient is sitting and the uh, you have opened the brain and the surgical site is above that of the heart. Then you can have posterior fossa syndromes, laparoscopic surgeries, and cesarean sections, then central venous access, epidural cannulations, even trauma and hypovolemia. They can all lead to venous air embolism. When we talk about the gas embolism, what is the pathophysiology of the gas embolism is that eventually what happens is that we have venous air embolism, so there is increase in the pulmonary vascular resistance. We have pulmonary artery pressure that is increased, and thus it can lead to pressure on the right ventricle, and we have a decreased venous return, decreased cardiac size, and eventually cardiac arrest. The same is going to happen if there is an air embolism or there is systemic arterial embolism. The clinical features of the embolism are pleuritic substernal chest pain. Please remember this. The characteristic feature of the pain is pleuritic substernal chest pain followed by arrhythmias, dyspneas, and confusion. In pulmonary embolism, you have just the opposite to that of malignant hypothermia, and we have a very, very sudden drop in EtCO2. You have hypoxemia, hypocarbia, non-cardiogenic pulmonary edema or negative pressure pulmonary edema, dry cough, hemoptysis. All these clinical findings are found in the patient of venous air embolism. How do you monitor? The most sensitive is transesophageal echocardiography, in which we have mill-wheel murmur, which is the characteristic finding of the venous air embolism. Please remember, it is mill-wheel murmur, and as small as 0.5 ml per kg of air could be lethal to the patient. Okay. The treatment if venous embolism occurs is the head has to be tilted down. Stop the surgery. If you have exposed vessel, kindly fill that entire area with normal saline. Okay, you increase the JVP of the patient. We have to stop all the nitrous oxide, because nitrous oxide is it can lead to expansion of the air embolism. We can use fluids, inotropes, and vasopressors in these patients for the resuscitation. Then this is something that you all have to remember: the nerve injuries, which is the most common injured peripheral nerve, that is your ulnar nerve. Most common injured nerve in lower limb is common peroneal nerve. Most common ophthalmic injury is corneal abrasion, and most common cause of post-operative visual acuity is ischemic optic neuropathy. Please remember whatever is written on the slide. The most common injured peripheral nerve is ulnar nerve. The most common injured nerve in lower limb is common peroneal nerve. The most common ophthalmic injury is corneal abrasion, and the most common cause of post-operative visual loss is ischemic optic neuropathies. Then we come to one thing, that what is post-anesthesia care unit? It is the unit which the patient is transferred after the operation has been done. Now, the most common physiological changes or the complications that can occur in post-operative unit is your most common is post-operative nausea, vomiting, followed by hypoxia. Hypoxia could be that the patient is still not out of anesthesia. There is a delayed awakening. We have edema of the airway. We have anesthetic agents which have still not been able to get washed out from the body. Then, other than edema of the airways, we can have basal atelectasis of the patient that can lead to hypoxia. Then we can have circulatory disturbances in post-op period. We can have post-op hypothermias also. When we talk about monitoring in post-anesthesia care unit, Every monitor has been used, whether it is respiratory, your history, airway patency, observation, cardiovascular, neuromuscular, TOF, temperature, pain, urine output, and if there is any drain, then checking of the drains. Post-operative complications, when we talk about, I told you mostly they're at the time of extubation, that the patient has not been extubated like fully conscious or awake. He's in some mid planes of anesthesia. So in respiration, we can have upper airway obstructions because the pharyngeal muscle tone is generally lost in patients, especially post-operatively. We can have hypoxemia and pulmonary edema. Then cardiovascular, if we see, then there are many post-operative complications of the cardiovascular system, which could be arrhythmias, it could be hypertension, and it could be tachy or bradycardias. The most common cause of death in post-operative period is your MI, myocardial infarction. Then you can have post-operatively renal dysfunction, that is AKI. Hypothermia, drug of choice is pethidine, and most common cause of hypothermia post-operatively is conduction, whereas intraoperatively it is radiation. You can have post-operative cognitive dysfunctions, you have emergence excitement, and lastly you have delayed recovery. In many patients we have delayed recovery. Then we can have a residual neuromuscular block which can lead to hypoxemia. So never extubate the patient if the TOF ratio of the patient is less than 0.9. There are other reliable parameters also which can help to detect whether the patient has been reversed properly or not. The thing that you have to know is there has to be a sustained head lift for 5 seconds. Similarly, hand grip, sorry, for 5 seconds. Negative pressure has to be developed around minus 40 centimeter water. We can have leg lift for 5 seconds. Or the tongue depressor test is positive. All these are reliable parameters for a successful extubation. Then yes, post-operatively you can have laryngospasm or the Larson's maneuver for the treatment that I have told you. We can have edema and hematoma post-operatively, especially if the OT had been in the prone position or Trendelenburg position. Then we can have hypoxemia post-operatively in the PACO unit, which could be due to atelectasis, that is basal atelectasis, especially seen in obese patients, pregnant patients, or in patients who had a long duration of surgery. We can have V by Q mismatch in patients. We can have diffusion hypoxia because the nitrous oxide was not stopped at least 10 minutes before the extubation. You can have hypotension in the patient, which can lead to hypoxemia, or the diffusion capacity of the patient, that is the parenchymal membrane, which is responsible for the exchange, could be distorted. Then post-operatively, we can have pulmonary edema, especially if we have given overzealous fluids to the patients and not the calculated ones. The patient can have cardiogenic pulmonary edema. The patient can have negative pressure pulmonary edema, especially seen in the patients of laryngo or bronchospasm. We can have transfusion-related acute lung injuries. We can have transfusion-related cardiac output which has been adversely affected. Then the most common complication post-operatively that I already told you about is the post-operative nausea, vomiting. See, PONV, what is majorly asked is that what is the scoring system which is used in PONV, and that is your MPhil score. The scoring system is nothing but MPhil score. Why does PONV occurs? The post-operative nausea vomiting is because of the trigger of the chemoreceptor trigger zone or the area prostrema. We have scores of MPhil which states that female gender, non-smokers, use of nitrous oxide, use of opioids, okay, and the history of PONV. All these are risk factors that of post-operative nausea and vomiting. If we think about the PONV, this is one of the topics which has to be done in detail. We have a history of PONV, or could be the predisposing factors like female gender, opioids, nitrous, history of the motion sickness, or they are non-smokers, or certain surgeries like the strabismus surgeries or the laparoscopic surgeries which are known to cause PONV. But the strategies of decreasing the PONV could be like regional anesthesia could be used. We can prefer total intravenous anesthesias over nitrous oxide. We can use regional blocks for post-op analgesia and decrease the use of opioids. We can have adequate hydration of the patient. The fasting status, the carbohydrate loading of the patient has to be done in order to decrease the chances of post-operative nausea, vomiting. We can avoid high dose of neostigmin because neostigmin is also known to cause PONV. Then your induction agents like etomidate, they can also cause PONV, and thus we can use propofol, which is anti-emetic. So if out of these risk factors, one or more risk factors is present, then we can have only a single agent to be used. You can use 5-HT3 antagonists like ondansetron. We can have droperidol, dexamethasone. If we have more than 3 factors, then we have to use a combination of the agents like ondansetron can be added to dexamethasone, or dexamethasone can be added to your say droperidol, or even you can have some non-pharmacological techniques like acupuncture, etc. can be used. But if it is many more factors which are present, then you can have a multimodal approach to PONV also. The best approach for the management of PONV, if asked, is multimodal. We have modal approach which is used. Now, one thing that is asked is about this drug, that is aprepitant. Aprepitant is the drug which is generally used for chemotherapy-induced nausea and vomiting. That is your aprepitant. Then you can have post-operative cognitive dysfunctions or delirium, which could be like immediately post-operatively, or it can extend up to 5 days also. Then you can have short-term memory loss also post-operatively. The drug of choice for such cases of psychosis is haloperidol. You can have emergence excitement, and lastly that I told you, we can have a delay in the awakening, and there are multiple reasons why there has been delayed in awakening. For example, if we think about the patient factors, old age patients, pediatric patients, then there could be certain genetic variables. If you all remember the pseudocholinesterase enzyme, right? Then the obese patients, patients which have decrease or some cognitive dysfunctions, seizures or stroke, they all can lead to delayed awakening. Then drug factors, the dose of the drug that you have used, the time of administration. Suppose you had given becuronium just 5 minutes before you have planned the extubation, or your inhalational agents were not stopped on time. So all this can lead to delayed in awakening. It depends upon the metabolism capacity of the body. The pharmacokinetics, the pharmacodynamics of the drug matters a lot. The dose of the drug that you have used, or the fluid overload or the fluid status that we are talking about. Then surgical factors could be like long surgeries, or you have given a large dose of muscle relaxant. Then you can have hypothermias, embolism, hypoxia, hypotension. They all can lead to delay in awakening. Then metabolic factors are your hyperglycemia, hypernatremia, your hypothermia, hypothyroidism, or acidosis or coagulopathies. There are so many factors that can lead to delay in awakening. Then before we discharge the patient, and before I end up this class also, I'd like to discuss about just 2 more scores that are your discharge criteria. Of course, not all the parameters of the discharge criteria, you cannot remember each and every condition, But yes, you have to remember the names of the two scores and the various parameters which are covered, not the complete score table. The first is modified Eldred score. See, modified Eldred score is generally used when we have to transfer the patient from the PACU to your ward. That is where you use Eldred score. Done. It has various parameters like consciousness. You see whether the patient is conscious or not. Then breathing, whether he's breathing perfectly or not. Circulation, what about the vitals of the patient you have to see, right? Then you have to see about the movement of the patient. Is the patient able to move the limbs or not? And lastly, your saturation is seen. Out of all these parameters, if more than 9 are positive or more than 9 is the score, it means that the patient can be easily discharged from the PACU to level 2. I repeat, you check the consciousness, the activity, your vitals, that is your SpO2 is checked, your breathing is checked, and your circulation is checked. Then we have PADS, that is the post anesthesia discharge scoring system, in which the patient is discharged to the home. This is the discharge scoring system to discharge from the home. This consists of your vital signs, your activity and mental status, how much orientation the patient has. It consists of your pain, nausea, vomiting, bleeding, surgical bleeding, and lastly the intake and output, whether the patient has voided or not. I repeat, the clinical discharge criteria, which mean that the patient's vital signs are stable, the patient is free of pain, the patient is free of nausea and vomiting, patient's conscious level is good, patient is alert, oriented, and patient has voided, and there is no bleeding. At that time, the patient can be discharged from the hospital to back to home. Lastly, I'll just want to discuss certain things like I already told you that when we talk about the complications, they are going to come to you in the form of case scenarios. For example, the patient could be like they could mention the OT temperature to you and the patient is having shivering. So what you have to do now? The next step would be that yes, you have to stop the shivering because shivering per se will lead to increase in the metabolic demand of the body and it can strain the heart because of the increase in oxygen consumption. So you have to stop shivering and the drug of choice for that is pethidine. Then the risk factors of postoperative nausea vomiting is asked. Uh, then desaturation, like the patient is being planned for extubation, but by mistake the nitrous oxide has not been closed on time. Then the patient desaturate as soon as the extubation occurred. So what could be the reason? The reason is that they are clearly stating in the case that nitrous oxide, they had forgotten to stop nitrous oxide, which can lead to diffusion hypoxia. Then you can have delayed reversal from the muscle relaxant. You have to be very careful that the TOF is more than 0.9 before you are extubating the patient. Plus, the delayed awakening could be because of multiple factors that I have just discussed. So, one of those factors can come as a question. Then you can have like aspiration pneumonitis, the case and that I've already told, like a pregnant lady is there, posted for emergency C-section. You took up the case in general anesthesia, and eventually and slowly you have an evolving ERDS in that patient. What could be the reason? The reason is aspiration pneumonia or Mendelssohn syndrome. Then lastly, you could have like 14-year-old was undergoing surgery and suddenly it was a strabismus surgery and suddenly you have increased abrupt and sudden increase in EtCO2 and high fever with hypertension, tachycardia and arrhythmias, and patient ABG is showing metabolic acidosis, such a gross thing which is clearly pointing towards malignant hyperthermia. So generally what the questions would be coming would be like a case scenarios. Out of this, you have to take out one or the 2 points which point to a certain type of condition, right? Lastly, I just want to highlight one of the anticholinergics which I had left in the last class. Anticholinergic with sedative as well as antiemetic property. That anticholinergic is your hyoscine. No, it's not hyoscine, it's your scopolamine. That is why scopolamines transdermal patches are also used to prevent your post-operative nausea vomiting, like they are used to prevent the motion sickness. So scopolamine is also used for prevention of your PONV. That's all about the complications of anesthesia. Thank you so much.